Okay, let's unpack this. Today, we're embarking on a deep dive into a subject absolutely fundamental for anyone stepping into fieldwork in an advanced hand therapy setting.
Hmm.
You've generously shared a wealth of sources with us, ranging from incredibly detailed clinical pearls on edema management to, well, the subtle intricacies of complex fracture patterns and the delicate nuances of nerve
Yeah,
injuries.
there was a lot there.
There really is. Our mission today is to truly extract the most important nuggets of knowledge regarding specific diagnoses you'll encounter, the essential tests and assessments you'll use in the clinic, and the wide array of interventions that will genuinely fill your clinical toolbox.
Right.
Think of this as your essential guide to confidently approaching real-world scenarios, packed with practical insights that will make a tangible difference on the floor.
And what's truly compelling here, I think, is how interconnected all these seemingly disparate aspects of hand therapy truly are. We're not just looking at isolated problems or, list of symptoms. We'll be connecting the dots,
Mm.
helping you understand how a bone heals, how a nerve responds to mechanical stress, and how even a seemingly simple intervention like a custom orthosis can profoundly impact a patient's entire recovery trajectory and their ability to function.
That's key.
Our goal is to give you not just the what and a deep, actionable understanding of the why behind each and every clinical decision you'll be making. The intricate landscape of hand diagnoses, what you'll encounter.
All right, let's begin by navigating the intricate landscape of hand diagnoses, because knowing what you're most likely to encounter is, well, it's more than half the battle in setting your clinical compass, right?
Absolutely, you need that roadmap.
We'll kick things off with some of the most common culprits you'll see walking through the clinic door: fractures of the hand and wrist.
Daily occurrence, really.
Here's a statistic that truly underscores their prevalence. A staggering 20% of all fractures in adults and children actually involve the hand.
Wow, 1 in 5.
Yeah. This isn't just a number. It means that in any busy hand therapy clinic, you're going to be seeing a hand fracture patient almost constantly. It underscores just how foundational this knowledge is and why mastering it early on is paramount for your fieldwork success.
Definitely.
And when we break that down further, about half of these hand fractures are metacarpals, those long bones in your palm, while the other half are phalangeal, meaning they involve the bones in your fingers.
Right, the finger bones.
Within the phalanges, you'll see them most often in the distal phalanx, then proximal, then middle, in that specific order.
Building on that point about the sheer frequency of these injuries, it's critical to understand that when the skeletal foundation of the hand is disrupted, when a bone is fractured, concomitant soft tissue injury is not just likely, it's almost a given.
Right, the force has to go somewhere.
Exactly. This isn't just about a broken bone in isolation. It's about the entire complex biomechanical system of the hand. The force strong enough to fracture a bone will inevitably wound the surrounding dense connective tissues, like the periosteum.
The bone lining.
Yeah. The lining of the bone, the joint capsule, the ligaments that provide stability, the tendons that move the joints, and even the delicate nerve sleeves. This soft tissue involvement is almost always present to some extent, whether it's subtle local swelling or edema or the very obvious trauma you'd see in an open fracture. This holistic view is essential because these soft tissue injuries, rather than just issues with bone healing, are actually the most common fracture complications.
Okay, that's a really key point, the soft tissue complications.
Yes, if not managed correctly, they can lead to functionally debilitating stiffness and deformity.
Mm.
And the impact isn't just physical. Hand trauma can also cause significant psychosocial issues,
Oh, absolutely.
leading to dependence on others for basic self-care and the inability to participate in usual work and leisure activities, which, as you know, is a huge part of a person's identity and well-being.
Definitely impacts quality of life. So let's zoom in on metacarpal fractures. These are incredibly common, and understanding them means recognizing the forces that cause them to displace.
Right, the mechanics of it.
One key insight for you to look for is the deforming forces at play. Most metacarpal fractures, in particular, tend to angulate dorsally, meaning they create a dorsal apex.
Pointing upwards on the back of the hand.
Exactly. This is a direct influence of the pull from the palmar interosseous muscles. It's fascinating, isn't it, how muscles, which are normally stabilizers, can become destabilizers when the skeletal integrity is compromised.
Yeah, they pull the fractured fragments out of alignment. It's a constant battle.
It's a very specific sliding scale, and while less angulation might be acceptable, it's crucial to understand the long-term functional implications of accepting certain degrees of deformity.
And that insight really sets the stage for understanding the profound functional impact of even seemingly small deformities like shortening and rotation.
Okay.
For instance, think about this. Every 2 millimeters of metacarpal shortening can lead to a noticeable 7 degrees of PIP joint extensor lag.
Wow, 2 millimeters, 7 degrees. That doesn't sound like much, but functionally.
Functionally, it's huge. To put that in perspective, think about the precision tasks the hand performs, how crucial those last few degrees of extension are for something as simple as threading a needle or fully grasping a coffee mug without discomfort. This seemingly small structural change can have a profoundly debilitating functional impact, and that's the real insight here.
Definitely.
And rotation, often overlooked, is equally critical. It can create what's known as scissoring of the fingers upon flexion.
Right, where they cross over each other.
Exactly. Normally, when you make a fist, all your fingertips should consistently point toward the scaphoid tubercle, that bony bump at the base of your thumb. But with rotation, each degree of metacarpal rotation can result in a remarkable 5 degrees, or 1.5 centimeters of finger overlap, making simple gripping or fine motor tasks incredibly difficult and potentially painful.
Okay, that's a huge multiplier. 1 degree means 5 degrees of overlap.
Yes, this is where you truly see the profound functional consequence of a malunion, a bone that heals in a deformed position.
Now, let's specifically highlight the boxer's fracture. This is the most common metacarpal fracture you'll encounter, and despite the name, it's rarely seen in skilled boxers who learn proper punching technique.
Right, it's more of the amateur punch-the-wall scenario.
Unfortunately, yes. It typically occurs from a fisted hand striking a solid object, most often involving the fifth or sometimes the fourth metacarpal. Surgery for these is typically considered if the dorsal angulation exceeds 15 degrees for the ring or small fingers, or 10 degrees for the index or long fingers.
Stricter for index and long.
Yes. If these guidelines aren't followed, it can lead to long-term issues that significantly impact function, such as lost active MCP joint flexion, a pseudoclad deformity where the finger curls up, and persistent pain in the palm during grip due to the metacarpal head shifting volarly.
That head drops down.
Metacarpal head fractures, on the other hand, are much less common but significantly more serious due to their intra-articular involvement, meaning they cross into the joint, often resulting from an axial load directly down the finger.
Into the joint space itself. Always more complicated.
Always. Non-surgical management for these is quite rare, only considered if less than 25% of the metacarpal head is involved and displacement is less than 1 millimeter. Very specific criteria.
That discussion about intra-articular involvement brings us perfectly to the unique challenges of thumb fractures, specifically those involving the first metacarpal.
Okay, the thumb. Critical for function.
Absolutely. While most extra-articular thumb metacarpal base fractures are stable after reduction, the intra-articular ones are far more complex, particularly those involving the highly mobile thumb carpometacarpal, or CMC, joint.
That saddle joint.
Exactly. A classic example is of Bennett's fracture. This is an intra-articular fracture dislocation of the thumb CMC joint, typically involving a single fragment of bone pulled off. While often stable after reduction, it can be complicated by the persistent pull of the abductor pollicis longus, or APL muscle.
Ah, the muscle pull again.
Yes, this muscle is a key dynamic destabilizer, constantly trying to pull the thumb out of its reduced position. A more forceful axial load can cause a Rolando's fracture, which is also an intra-articular comminuted fracture of the thumb CMC joint, but with 3 or more fragments forming a distinctive T or Y configuration.
Comminuted means multiple pieces, right?
Multiple pieces, shattered, essentially. Surgical stabilization is almost always required for these more complex fractures to restore the articular surface of this mobile, load-bearing joint, which is crucial for pinch and grasp.
Makes sense.
Shaft fractures of the thumb metacarpal are relatively rare, usually transverse or oblique, and dorsal angulation over 30 degrees suggests the need for reduction. Finally, we have the metacarpal head avulsion, commonly known as skier's thumb.
Or gamekeeper's thumb.
Or gamekeeper's thumb, exactly. This is a very common injury, resulting from radial forces straining the thumb's MCP joint ulnar collateral ligament, or UCL, or causing its avulsion, meaning a piece of bone is pulled off with the ligament.
So the ligament pulls the bone off.
Precisely. Protected immobilization can suffice for non-displaced avulsions, but displaced avulsions almost always require surgery to ensure a stable, pain-free thumb for all those essential grasping and pinching activities.
Moving beyond the metacarpals, let's talk about phalangeal fractures, meaning fractures of the individual bones in your fingers and thumb.
Okay, down to the fingers themselves.
The proximal interphalangeal, or PIP, joint is a common site for fracture dislocations, usually due to axial compression. Think of a finger getting jammed.
Like jamming it on a basketball.
Exactly. Dorsal dislocations, where the middle phalanx moves dorsally, are more common. But if the middle phalanx moves volarly, it's a volar dislocation, and these are particularly problematic because they can lead to a boutonniere deformity.
The buttonhole deformity.
Yes, which presents as PIP joint flexion and DIP joint hyperextension, often due to an injury to the extensor central slip. When it comes to distal phalanx fractures, or P3 fractures, these are the most exposed bones in the hand, making them highly vulnerable.
Tips of the fingers.
Tips of the fingers. The long finger P3 is most frequently involved. They're often crush injuries, like getting a finger caught in a door, which, as you can imagine, is excruciating.
Yeah, and often messy with nail bed involvement.
Absolutely. A key point here is that the flexor digitorum profundus, or FDP muscle, that's the one that flexes the very tip of your finger, can actually pull the shaft fracture dorsally, adding to the deformity.
Another muscle causing trouble.
Always. And because of the nature of these crush injuries, soft tissue injuries like nail bed trauma, hematomas, digital nerve damage, or even extensor tendon lacerations are extremely common, often overshadowing the bone injury itself in terms of long-term complications.
That insight into the FDP's pull is a perfect example of how complex these seemingly small bone injuries can be. And it leads us to another fascinating area: how specific forces can lead to specific avulsion fractures of the distal phalanx.
Okay.
Take the FDP avulsion, famously known as jersey finger.
Right, grabbing the jersey.
Exactly. This occurs from forced extension of a flexed DIP joint, typically when a football player grabs another player's jersey and the fingers abruptly pulled straight. This injury almost always requires surgical management to reattach the FDP tendon.
Needs fixing.
Needs fixing. In stark contrast, the terminal extensor tendon avulsion, or bony mallet finger, results from forced DIP flexion, like a ball hitting an extended finger and forcing it to bend at the tip.
So the opposite mechanism, really.
The opposite. Non-surgical management is typical for these, often with continuous splinting, especially if less than 30% of the joint surface is involved and the fracture reduction is successful.
Splinting for weeks.
Weeks and weeks, yes. As for thumb phalanges, P2 fractures, meaning fractures of the proximal phalanx of the thumb, are the second most common after long finger P3 fractures. Here you might see avulsions of either the extensor pollicis longus, or EPL, or the FPL.
Extensor or flexor tendon pulling off bone.
Exactly. Generally, FPL avulsions are more likely to require surgery than EPL avulsions, which can often be managed non-surgically, similar to a bony mallet finger.
Now let's shift our focus to wrist fractures and instability, a truly complex area given the intricate mechanics of the carpal bones.
Oh yeah, the wrist is a whole different ballgame.
Distal radius fractures, or DRFs, are incredibly common, often from falls, and unstable DRFs almost always require surgery to ensure proper alignment and healing.
Fall on outstretched hand, fauche injury.
Classic. When you're evaluating these, you always need to be aware of potential secondary ulnar fractures. Sometimes the ulna breaks too. And any loss of radial height, which can have long-term consequences for wrist mechanics and pain.
That radial tilt and height are critical.
Absolutely. Carpal fractures are also a big part of hand therapy practice. The scaphoid is by far the most frequently fractured carpal bone, accounting for an astounding 80% of all carpal fractures.
80%. Wow. Just the scaphoid.
Just the scaphoid. It's often seen in young males averaging around 25 years old, involved in sports or manual labor. The waist of the scaphoid is the most common fracture site, accounting for 70% of these injuries, but fractures of the proximal pole and distal tubercle also occur.
And that blood supply issue is huge with the scaphoid, right? Especially the proximal pole.
Exactly. Less common but still important are triquetrum and trapezium fractures. Given the scaphoid's tenuous blood supply, these fractures are notorious for complications, which leads us to.
And that leads perfectly into the critical complications you must recognize if these fractures don't heal correctly. We're talking about malunion, non-union, and fibrous union.
The unions.
The bad unions, yes. Malunion occurs when a fracture heals, but with malignment, leading to pain and loss of motion and function. Non-union is when the bone completely fails to heal, leaving a persistent gap. And fibrous union is when it heals with unstable fibrous tissue, not true bone, leading to a floppy, painful joint.
So, healed wrong, didn't heal, or healed weakly.
Pretty much. These can result from poor reduction, meaning the bones weren't set correctly, too much micromotion during healing, or even systemic health factors and medication use. As we noted at the top, soft tissue injuries are always present to some extent with fractures.
Right, back to the soft tissues.
Always back to the soft tissues. This can lead to significant carpal ligament injuries with a high incidence reported. 50% for scapholunate, SL, ligament tears, and 15% for lunotriquetral LT ligament tears. These are key stabilizers of the wrist.
SL and LT tears, very common with wrist trauma.
Very common. Tendon irritation or even rupture can also occur post-fracture, often from hardware rubbing against tendons or friction, which typically requires surgical repair. Nerve compression or irritation is another significant concern.
Nerves getting pinched.
The median nerve is most commonly involved, leading to conditions like acute carpal tunnel syndrome, but dorsal radial sensory nerve, DRSN, or ulnar nerve irritation can also occur, causing pain and numbness.
And here's one of the most debilitating and frightening complications you might encounter: complex regional pain syndrome, or CRPS.
Oh, CRPS. Yeah, that's a tough one.
It's a significant concern post-DRF, and studies suggest that a pain level of 5 or greater on a 10-point scale in the first 3 postoperative days can actually be linked to an increased incidence of CRPS.
Interesting. So early high pain is a warning sign.
Potentially, yes. It involves neuropathic pain, vasomotor dysfunction, meaning changes in blood vessel function, affecting temperature and color, and can lead to extreme stiffness and significant disability far beyond the original injury. Early detection and a multidisciplinary treatment approach are absolutely key for managing this complex condition.
It really takes a team.
It does. Finally, let's talk about wrist instabilities. These are classified using systems like carpal instability dissociative, or CID, carpal instability non-dissociative, or CIND, carpal instability complex, or CIC, and carpal instability adaptive, or CIA.
Lots of acronyms there.
Lots of acronyms, but they describe different patterns of carpal bone instability. These are often linked to ligamentous disruption, particularly the scapholunate and lunotriquetral ligaments. It's important to consider the concept of the dart-throwing motion,
That diagonal movement.
which incorporates radial extension and ulnar flexion. This is a very common movement pattern in activities of daily living. Instability profoundly affects this motion. For instance, healthy wrists show little scapholunate joint movement during this motion, while injured wrists show obvious gapping.
You can almost see the instability sometimes.
You can. TFCC, that's the triangular fibrocartilage complex, and distal radial node joint instability can also occur, often following trauma or a DRF, causing ulnar-sided pain, clicking, and a feeling of the wrist giving way.
That ulnar side pain is a big clue for TFCC.
All right, moving beyond acute fractures, let's delve into tendinopathies, conditions often linked to overuse and degeneration, which you will see constantly in the clinic.
Yeah, the itises and oses. Very common.
Tendons are truly fascinating structures. They're viscoelastic, meaning they can stretch and return to their original shape, much like a spring, and their primary job is to transmit muscle forces, creating motion at joints.
Force transmission.
But their biomechanical properties aren't fixed. They're dynamic, living structures, constantly adapting or struggling under the influence of age, hormonal shifts like pregnancy, and how much they're mobilized or immobilized. With aging, for instance, their tensile strength naturally decreases.
They get less resilient.
Exactly. The critical point here is that chronic degeneration often leads to scarring and length insufficiency within the tendon, which can profoundly impact function and lead to persistent pain.
So it's often degeneration, not just inflammation, especially in chronic cases. That's the osis part.
Right, that's a key distinction, tendinosis versus tendinitis.
And that explanation of tendon mechanics brings us directly to how these tendinopathies present in the clinic. Take lateral epicondylosis, which you probably know better as tennis elbow.
The classic.
This condition is characterized by pain over the lateral epicondyle, that bony bump on the outside of your elbow, and it's significantly exacerbated by resisted pronation and wrist flexion. What's crucial to note here, and a common differential diagnosis you'll grapple with, is the importance of ruling out radial tunnel syndrome, as their pain patterns can overlap.
The nerve mimicking the tendon issue.
Can happen. Conversely, medial epicondylosis, or golfer's elbow, presents with pain over the medial epicondyle, that bony bump on the inside of your elbow, similarly exacerbated by resisted pronation and wrist flexion.
Inside elbow pain this time.
Right. While the underlying causes are different, the aggravating movements are quite similar, requiring careful assessment to differentiate.
Then there's de Quervain's tenosynovitis, which involves impaired gliding of two specific thumb tendons, the abductor pollicis longus, APL, and the extensor pollicis brevis, EPB.
APL and EPB in the first compartment.
Exactly. These tendons run through a tight tunnel in the first dorsal compartment of your wrist, and the condition is often due to thickening of the extensor retinaculum, the fibrous band that holds them down. Clients typically report pain over the radial styloid, which is that bony bump on the thumb side of your wrist.
Right over that bump.
And it can radiate distally to the thumb, or proximally towards the shoulder. It's most common in females aged 35 to 55 and is often associated with the dominant hand, particularly in new mothers, due to repetitive lifting.
The new mom's thumb. Very common presentation.
Very common. And finally, trigger finger, or digital stenosing tenosynovitis. This is characterized by a distinctive snapping, popping, or catching sensation of the flexor tendon, usually at the A1 pulley, which is a fibrous arch at the base of your finger.
That pulley system gets tight.
It does. It's caused by a mismatch in volume between the tendon sheath and its contents, where the tendon becomes swollen and can't glide smoothly. You'll observe pain with palpation at the pulley, locking and flexion, especially in the morning, and pain with gripping activities.
That morning locking is a classic sign.
It is. It's common in women in their 50s and 60s, and notably, it has a higher incidence in diabetic patients. It can also affect multiple fingers or even thumbs in infants.
Interesting, the diabetic link. That exploration of localized tendinopathies naturally leads us to a broader, more profound challenge in hand therapy. Nerve injuries, which can range from subtle palsies to chronic pain conditions.
Nerves are definitely complex.
They are. Understanding peripheral nerve anatomy and injury mechanisms is truly foundational to effective treatment. Nerves are incredibly well protected by multiple connective tissue layers. The outermost layer is the epineurium, which provides tensile and compressive protection.
Outer shell.
Then the mesoneurium, which allows the nerve to slide and move freely. Next, the mechanically strong perineurium, serving as a molecular diffusion barrier and tensile protector, essentially keeping things out of the nerve.
The gatekeeper layer.
Kind of, yeah. And finally, the innermost endoneurium, which supports individual nerve fibers and provides essential electrical insulation. Here's a crucial clinical pearl to remember throughout your career. Motion is lotion for our nerves.
I like that. Motion is lotion.
Why? Because movement enhances both blood flow and exoplasmic flow within the nerve, which is vital for nerve health, nutrient delivery, and waste removal. Nerves need to move.
That's such a powerful and memorable way to put it. And when nerves do get injured, there are essentially two primary pathological responses. Demyelination, which causes a slowing or complete loss of conduction, much like insulation wearing off a wire.
Signal gets fuzzy or stops.
Exactly. And or direct injury to the nerve fiber itself. Seddon's classification is crucial for understanding the severity of nerve injury and therefore the prognosis.
Seddon's, neuropraxia, axonotmesis, neuromesis.
Right. Neuropraxia involves transient conduction disruption with an intact endoneurial tube, meaning the nerve is bruised but not cut, so there's generally a good prognosis.
Like when your foot falls asleep, sort of a temporary thing.
Sort of, yeah, a physiological block. Axonotmesis is more severe, with the nerve fiber disrupted, meaning the axon is damaged, but still intact endoneurial tubes, leading to Wallerian degeneration, where the nerve fiber distal to the injury site breaks down and clears the pathway for potential regrowth.
So the wire inside is broken, but the outer tube is okay. Recovery is possible, but slower.
Right. Needs time to regenerate. While more serious, there's still a good chance of recovery, often without surgery. The poorest prognosis is neuromesis, which is complete severance of the nerve, almost always requiring surgical intervention for any functional recovery, as the nerve needs to be reconnected.
Cut completely. Needs surgery.
Needs surgery. It's quite remarkable that even seemingly simple external compression can be impactful. For example, if you hold your wrist at 90 degrees of flexion or extension, it can increase carpal tunnel pressure to 30 millimeters of mercury, potentially creating a temporary neuropathy.
Doesn't take much pressure sometimes.
Not always. And with a completely severed nerve, you'll see a complete loss of sensation, muscle control, and reflexes distal to the injury, with the best surgical prognosis if intervention occurs within 48 to 96 hours of the injury.
Time is critical for nerve repair. Building on that understanding of nerve injury mechanisms, let's delve into specific nerve injuries of the upper extremity, starting with the radial nerve.
Okay, the nerve that extends the wrist and fingers.
Primarily, yes. For low radial nerve injuries, we look at two distinct conditions. posterior interosseous nerve, or PN syndrome, and radial tunnel syndrome, or RTS.
PIN and RTS.
PN syndrome typically presents with weakness or paralysis of ulnar wrist extension, digit extension, and thumb extension radial abduction, often accompanied by a deep ache in the proximal lateral forearm. The classic sign is difficulty extending the fingers.
So motor loss is key for PN.
Motor loss is key. RTS, on the other hand, primarily presents with pain, but no clear motor loss, making it a pain-dominant condition, often a deep aching pain without obvious muscle weakness.
Pain without the weakness. Tricky to diagnose sometimes.
Can be. Another important radial nerve issue is dorsal radial sensory nerve, or DRSN, irritation, also known as Wartenberg syndrome. This causes pain and dysesthesia, which are abnormal sensations like burning or tingling on the dorsal radial hand, thumb, index, and long fingers.
Sensory only, on the back of the thumb side.
Exactly. It's often caused by compression between the brachioradialis and ECRL tendons during pronation, or by scar tissue that forms after a distal radius fracture, or de Quervain's release surgery.
Shifting to the median nerve, high or proximal median nerve palsies include pronator syndrome, where the nerve is compressed between the pronator teres heads or under the flexor digitorum superficialis, or FDS, arch.
Compressed up in the forearm.
Right. This causes diffuse pain in the medial forearm and dysesthesia, that burning or tingling in the radial 3.5 digits. Then there's anterior interosseous nerve, or AI, palsy, which is quite distinct and purely motor.
AI is just motor, no sensory loss.
Correct. It causes paralysis of the flexor pollicis longus, FPL, the muscle that flexes the tip of your thumb, and the index and long finger FDP, leading to a classic O-sign difficulty when trying to make a circle with the thumb and index finger.
Can't make that OK sign properly.
Exactly. Moving distally, the low distal median nerve palsy, commonly known as carpal tunnel syndrome, or CTS, is the most common entrapment syndrome you will encounter.
The king of entrapment neuropathies.
It really is. It manifests as paresis, meaning weakness or loss of the thenar muscles, which are those muscles at the base of your thumb, leading to weakness or loss of thumb opposition, and sensory loss in the thumb, index, and long fingertips.
Weakness in the thumb muscles, numbness in the first three fingers.
Classic symptoms include nocturnal discomfort, often waking patients up, dropping objects, and difficulty with fine motor tasks like buttoning a shirt.
That night pain is a huge clue for CTS. And that brings us to the ulnar nerve. Cubital tunnel syndrome involves compression of the ulnar nerve at the elbow, often within a tight tunnel.
The funny bone nerve getting pinched at the elbow?
Exactly. This leads to sharp or aching pain, decreased sensation or a feeling of coldness in the ulnar digits, your ring and small fingers, and motor weakness or wasting of the ulnar innervated intrinsic muscles of the hand, ultimately resulting in decreased power grip.
Weakness in the hand, intrinsics, numbness in the little and ring fingers.
Precisely. In advanced cases, you'll see a distinctive claw hand deformity, characterized by hyperextension of the MP joints, the knuckles at the base of your fingers, and flexion of the IP joints, the joints within your ring, and small fingers.
The ulnar claw.
This compression is most pronounced when the elbows flex beyond 110 degrees as the cubital tunnel space becomes smallest in this position.
Like talking on the phone or sleeping with bent elbows.
Exactly those activities. Distally, Guillon's canal compression at the wrist can occur due to various causes like pisiform or hamate fractures, arthritis, or a mass. Symptoms include pain, intrinsic muscle weakness, and dysesthesia in the ulnar distribution.
So ulnar nerve issues, but down at the wrist this time.
Right. Different location, similar nerve. Finally, regarding digital nerves, which are the smallest nerves in the fingers, lacerations often lead to persistent issues like hypersensitivity or hyperesthesia, where even light touch feels painful, and significant cold intolerance, which can be quite debilitating for patients, especially in colder climates or occupations.
Yeah, that cold intolerance can be a really big functional problem. While not strictly hand injuries, brachial plexopathy and thoracic outlet syndrome, or TOS, are incredibly important to understand due to their profound impact on the entire upper extremity, right down to the hand.
Absolutely. Issues higher up the chain.
You'll often find it's more of a brachial plexopathy, meaning an issue with the nerve network coming from your neck and shoulder, than true vascular TOS, as vascular presentations are relatively uncommon.
Mostly nerve compression, not blood vessel compression.
Usually. Symptoms can be quite varied and confusing, making diagnosis challenging. Unilateral headaches, particularly in the back of the head, facial pain ranging from the jaw to the ear, shoulder and chest wall pain, and even swelling or flushing of the face and ear.
Wow, that's a wide range of symptoms.
It is. Patients might also experience numbness or arm pain, for instance, affecting digits 1 to 3. It has an increased incidence in women and often has an insidious onset, meaning it develops gradually without a clear inciting event. Interestingly, it can sometimes be misdiagnosed as cardiac events,
Whoa.
which highlights the importance of a thorough differential diagnosis and comprehensive upper extremity evaluation.
That insight into the systemic nature of these conditions leads us to a crucial principle: the proximal influence of the shoulder on distal hand function.
Everything's connected.
Everything is connected. The shoulder's primary role, when you think about it, is to position the hand in space, allowing for interaction with the environment, whether you're reaching for a cup or typing on a keyboard. Therefore, dysfunction in the shoulder complex profoundly impacts the entire upper extremity.
Can't use your hand well if you can't get it where it needs to go.
Exactly. A hand therapist treating elbow or wrist issues must monitor shoulder health, as compensation at the shoulder for distal limitations can lead to its own dysfunction over time. This means a truly holistic view of the entire limb, from the neck down to the fingertips, is non-negotiable for optimal patient outcomes.
So let's touch on some common shoulder diagnoses you might see influencing hand therapy. Proximal humerus fractures are the most common humerus fracture, typically resulting from a fall, especially in the elderly.
Common in older adults, yeah.
Most are stable one-part fractures involving the surgical neck of the humerus, which is good news for recovery, often allowing for non-surgical management. Then there's adhesive capsulitis, commonly known as frozen shoulder, a condition with distinct, often painful phases.
Frozen shoulder, painful and stiff.
Very. The freezing phase is characterized by significant pain, often interrupting sleep and activities of daily living, with pain often occurring before the end range of motion is even reached. This phase can last anywhere from 2 to 9 months.
The painful phase.
Right. The frozen phase can last up to a year, marked by distinct pathological movement patterns where pain only occurs at the very end of motion, but range of motion is severely restricted.
Stiff phase. Less pain, more stiffness.
Exactly. And finally, the thawing phase, where motion gradually returns, potentially lasting up to 26 months.
Long recovery sometimes.
Can be. A key consideration here, and something that often surprises new therapists, is that overstretching during the freezing phase can actually enhance inflammation and prolong recovery.
Right, got to be gentle in that early painful phase. Don't push through the pain.
Exactly. Additionally, modalities like ultrasound or interferential e-stim have not been shown to affect the outcome, and in some cases may even prolong recovery by creating more inflammation if applied incorrectly during the freezing phase.
So maybe skip the modalities early on.
Mm-hmm.
Focus on gentle motion and pain control.
That seems to be the takeaway.
That insight about the phases of frozen shoulder and the caution with modalities is incredibly important, and it leads us to consider another common shoulder issue: shoulder instability. We often classify it into two main types, simplified by the acronyms 2BS and MBI.
TBS and MBI, okay.
2BS stands for traumatic, unidirectional, Bankart surgery, and typically involves a history of dislocation, usually anterior, often with Bankart lesions, which are damage to the anterior glenohumeral capsule, and glenoid labrum or Hill-Sachs lesions, an osseous defect on the back of the humeral head.
So traumatic dislocation usually needs surgery.
Usually. These types of instabilities almost always require surgery to achieve stability. In contrast, AMBI stands for atraumatic, multidirectional, bilateral rehabilitation, inferior capsular shift, interval closure.
Okay, traumatic, so no specific injury.
Often not. This type is often associated with generalized ligamentous laxity, meaning a person is naturally double-jointed, and typically responds much better to rehabilitation efforts focusing on strengthening and control.
So rehab is key for MBI.
Rehab is often the first line. Finally, rotator cuff, or RC, pathology, whether it's tendinitis or a full-blown tear, can be intrinsic, meaning age-related degeneration often at the critical zone of the supraspinatus tendon.
Wear and tear.
Or extrinsic, due to impingement where the tendon gets pinched. Partial thickness tears can certainly progress to full tears. This pathology leads to decreased strength and function, and in the severe cases, the inability to elevate the arm above horizontal, profoundly impacting the hand's ability to be positioned for any functional use.
Can't lift the arm, can't use the hand effectively. Makes sense. 2, unpacking the assessment toolbox, knowing what you're seeing. All right, now that we've thoroughly covered the landscape of diagnoses, let's pivot to perhaps the most critical skill in fieldwork: assessment. Knowing what you're truly seeing in front of you starts with mastering objective measurements and provocative tests.
Yeah, assessment is everything. You can't treat what you don't assess properly.
Exactly. And nowhere is objectivity more important than an edema assessment. Here's a vital clinical pearl that often surprises new therapists with its simplicity. Edema fluctuates constantly due to factors like activity level, time of day, and fluid retention.
It changes throughout the day.
It really does. So, to most objectively measure changes and truly track your patient's progress, you must always measure with the same therapist at the same anatomical position using the same tool and at the same time of day.
Consistency, consistency, consistency.
Consistency is paramount and will be your best friend in demonstrating progress to patients and other clinicians.
And that insight into consistency is key to accurate assessment. What's fascinating here is the evolution of how we assess edema. While the client's still gasted, you might rely on more subjective terms like mild, moderate, or severe, and note whether the edema feels pitting, meaning it indents when you press it, or brawny, which is a firmer, fibrotic type of swelling.
So descriptive terms initially.
Initially, yes. However, once that cast is off, you absolutely need objective, quantifiable data. This is where methods like the figure-of-8 method, which involves wrapping a tape measure circumferentially in a prescribed way around the wrist and hand,
That specific pattern.
or volumetric measurements, submerging the hand in a container of water to measure displacement, become essential for tracking progress. These give you hard numbers that demonstrate change, which is incredibly motivating for patients.
Seeing the numbers go down, yeah. Shifting to fracture healing, there's a simple yet powerful clinical pearl for assessing bony healing that you'll use constantly. Firm palpation directly over the fracture site.
A poke test.
Kinda, yeah. If the fracture has clinically healed, meaning it's stable enough, the client generally won't report pain when you press on it. If it's still healing, it will typically be tender.
Simple but effective feedback.
Very effective. This gives you immediate, real-time feedback on healing progression, often before an X-ray confirms it. And of course, regular X-ray follow-up is critical for monitoring alignment throughout the healing process, ensuring the bones are staying in the correct position.
Got to make sure it's healing straight.
Absolutely. When you're assessing any patient, always consider their current overall health, their medication use, which can impact healing, for example. NSAIDs can slow bone repair, their psychosocial status, and their cognitive abilities, as all of these can significantly influence both healing and their ability to participate fully in rehabilitation. It's a holistic picture.
That point about integrating the patient's overall health is so crucial as it impacts everything we do. And it leads us to consider how we assess tendinopathies to pinpoint the source of pain.
Finding the culprit tendon.
Exactly. For Ducravane's tenosynovitis, you'll palpate directly over the first dorsal compartment. A classic provocative test, one you'll perform daily, is Finkelstein's test.
Finkelstein's. Thumb and fist, ulnar deviate.
You got it. You instruct the client to flex their thumb into their palm, then make a fist around it, and finally, ulnarly deviate their wrist, meaning bend it towards the little finger side. If this maneuver reproduces their symptoms, it's considered a positive test, indicating irritation of those two thumb tendons. Resisted APL, or abductor pollicis longus, is also a good indicator of pain.
Okay.
For trigger finger, palpation at the A1 pulley, that area at the base of the finger on the palm side, is key. You'll also observe for locking and flexion, especially in the morning, their inability to make a full fist, any swelling over the distal palmar crease, and the presence of a PIP joint flexion contracture, where the middle joint of the finger can't fully extend.
Looking and feeling for that trigger.
Exactly. While specific details for epicondylosis provocative tests weren't extensively covered in our sources, the concept of using specific movements or resisted actions to provoke symptoms and identify the involved tendon is a general principle you'll apply across all tendinopathies. It's about finding the movement that hurts and then linking it to the specific structure involved.
Makes sense. Provoke the pain to find the source. Now, let's move into nerve injury assessments. Truly unraveling sensation and motor function is one of the most complex yet rewarding aspects of hand therapy.
Oh yeah, sensory testing is an art and a science.
When it comes to sensory testing, the Semmes-Weinstein monofilament test is considered the gold standard. This uses a kit of nylon probes of varying stiffness to map light touch sensibility.
Little plastic filaments.
Exactly. While the full kit has many probes, you'll find yourself reaching for a few key ones, like the 2.83, which indicates diminished light touch, or the 4.31, which signifies a loss of protective sensation.
That 4.31 is a big one. Loss of protective sensation means risk of injury.
Huge risk, which is vital for patient safety and preventing further injury. To perform it, you demonstrate on normal skin, have the client close their eyes and say yes when they feel a stimulus, and stabilize their hand to prevent false positives. This gives you a graded, objective measure of nerve function, crucial for tracking recovery.
And that leads perfectly into the hierarchy of sensory return and its functional implications. Two-point discrimination assesses the ability to distinguish between 1 versus 2 points of pressure on the skin.
1 point or 2.
Right. Importantly, moving two-point discrimination returns before static two-point discrimination during nerve regeneration. So test moving first.
Okay, test moving 2 point first. Good tip.
Moberg suggests specific thresholds for functional tasks, which provides a tangible benchmark for recovery. 6 millimeters is needed for winding a watch, 6 to 8 millimeters for sewing, and 12 millimeters for using precision tools like wrenches.
Connecting the measurement to actual function.
Exactly. It helps you explain to a patient when you can feel 2 points at X distance, you'll be able to do Y. Localization of touch is another crucial test. It requires a more integrated perception than just feeling a stimulus. The client points to the exact spot touched with their eyes closed. This is incredibly useful for planning sensory re-education, as difficulty localizing is common after nerve injury and needs specific retraining. The Moberg pickup test is particularly useful for assessing median nerve function, or for children and cognitively impaired adults who may struggle with other, more abstract tests, as it's a timed functional test involving picking up small objects.
More functional, less abstract.
Right. And the Orion wrinkle test provides a truly objective measure of denervation. Denervated skin that has lost its nerve supply, does not wrinkle when soaked in warm water, specifically 40 degrees C or 104 degrees Aerofan for 30 minutes.
Wow, that's fascinating. No wrinkles means nerve damage.
It's a fascinating and quick visual cue for nerve damage.
Shifting to motor function, manual muscle testing, or MMT, is crucial for documenting paresis, meaning weakness, or paralysis resulting from a peripheral nerve lesion.
Gotta test the strength.
Always compare strength to the uninvolved side to establish a clear baseline and track recovery. A critical precaution you must always remember. Do not perform MMT for strengthening unless you have clear physician clearance, especially after a nerve repair, as too much stress can disrupt the delicate healing.
Right. Assess. Don't stress the repair early on.
Exactly. When performing MMT, apply resistance in the mid-range of available motion and use simplified grading systems to make documentation clear and consistent. You'll also rigorously look for trophic changes.
Those subtle skin and nail changes.
Yes, characteristic alterations in tissues distal to the injury, indicating sympathetic and sensory dysfunction that the nerve supplies. These include subtle nail changes like blemishes or a talon-like appearance, abnormal hair growth, either falling out or becoming longer and finer cold intolerance, soft tissue atrophy, most notably a flattening of the fingertip pulps, and a slowed rate of tissue healing. These are all subtle yet powerful indicators of nerve involvement.
And that brings us to a hallmark sign of nerve regeneration, Hoffman-Tinel sign.
Tinel's tapping.
Exactly. Gentle percussion along the course of the injured regenerating nerve produces a temporary tingling sensation in the distribution of that nerve up to the site of regeneration. You test from distal to proximal, moving your tap upwards towards the injury site.
Following the nerve regrowth.
Hopefully. A progressing Tinel's sign, meaning it moves more distally over time, is encouraging for nerve recovery, though it doesn't necessarily predict complete recovery. Conversely, its absence or lack of progression over time can indicate a poor prognosis, suggesting the nerve isn't regenerating.
So a moving Tinel's is good news, a stuck one isn't.
Generally, yes. Pain assessment is also fundamental, as pain can profoundly limit function. You use single-dimensional scales like the Visual Analog Scale, or VAS, the Numeric Rating Scale, or NRS, or the FACES Pain Scale revised for immediate outcomes and quick quantifiable data.
Quick pain scores.
Right. For a more comprehensive view of the dynamic, multidimensional pain experience, considering social, cultural, cognitive, and emotional factors, a multidimensional scale like the McGill Pain Questionnaire can be incredibly helpful. Remember, pain is dynamic, not a stable state.
It changes.
Always. Cold sensitivity or intolerance is another common and often debilitating consequence of peripheral nerve injuries. Self-report is incredibly important here, as it directly relates to functional impairment and a client's ability to return to work or leisure activities, particularly in cold environments.
Don't underestimate the impact of cold sensitivity.
Never. Other considerations you might encounter include assessing reflexes, although hyperflexia isn't always a great guide to severity, and sometimes an electromyography or EMG might be needed to confirm nerve compression, for instance, in pronator syndrome.
EMG for electrical confirmation. Now let's bridge proximal and distal function by looking at shoulder assessment. Your general approach should always begin with a global ROM assessment of the client's shoulder and elbow to quickly identify any limitations that might be impacting their hand.
Gotta look upstream.
Always look upstream. Observe carefully how they hold their arm. Is it guarded and stiff, relaxed, or in a sling? These observations can provide early clues about pain and protection. Also, compare sympathetic changes to the uninvolved side, looking for differences in vasomotor, meaning temperature, color, or swelling pseudomotor or sweating patterns, pilomotor goosebumps, and trophic responses, changes in skin, nail, or hair growth.
Looking for those CRPS-type signs again.
Exactly. This is important for identifying potential autonomic instability often seen in nerve-related issues like CRPS.
And that keen observation leads us to a critical step: cervical spine screening. Before attributing all shoulder or arm pain to the shoulder itself, you absolutely need to rule out cervical radiculopathy, meaning pain originating from nerve roots in the neck.
Got to clear the neck first.
Always clear the neck. You'll perform cervical rotation and specific provocative tests like Sperling's A and B. Sperling's A involves laterally flexing the neck to end range towards the affected side, followed by axial compression. Sperling's B adds cervical extension and ipsilateral rotation before axial compression.
Trying to reproduce neck-related symptoms.
Exactly. These tests stress the facet joints and can provoke symptoms if pathology is present in the neck, indicating a cervical origin of pain. The cervical distraction test, where you gently grasp the client's chin and occiput and apply axial traction, can help alleviate symptoms originating from cervical nerve root compression, providing a clear diagnostic clue.
Pulling up might make it feel better if it's the neck. For thoracic outlet syndrome, or TOS, or brachial plexopathy, your assessment starts with observation. Look for any asymmetry in scapular or shoulder position, or any swelling over the supraclavicular fossa, that little hollow just above your collarbone.
That spot above the collarbone can be telling.
It can. Autonomic instability is a key sign, so monitor for reticular modeling, a lace-like pattern on the skin, and changes in color or temperature of the limb, or unusual sweating patterns. Palpate along the course of the brachial plexus and peripheral nerves for tenderness and to elicit a Tenel sign.
Tapping along the plexus.
Right. To assess neural mobility, the Ruth East test is commonly used, where the client holds their arms in a stick-up position, elbows bent at 90 degrees for 1 to 3 minutes, assessing for symptom reproduction or fatigue.
The hands-up test.
Basically. For sensory acuity, using a safety pin with tape can help keep the pressure constant when checking sharp sensation. And here's a fascinating detail you'll learn to appreciate. Differential sensation, meaning a difference in feeling in the middle versus the ring finger, can actually indicate involvement of the medial versus lateral cord of the brachial plexus.
Wow, that's specific. Middle versus ring finger.
That's specific. It provides a precise diagnostic clue for the location of the nerve compression.
That detailed approach to TOS leads us to consider how we assess shoulder instability. First, you should always screen for general connective tissue laxity using the Baton scale, where a score greater than 4 out of 9 indicates hypermobility, suggesting a tendency for looseness in joints.
Checking for general bendiness.
Pretty much. Your primary goal in assessing shoulder instability is to find the direction or directions of instability. Is it anterior, posterior, or multidirectional? And reproduce the client's symptoms. Client relaxation is absolutely critical during this examination,
Gotta get him to relax those muscles.
as muscle guarding can effectively hide the true degree of instability, making your job harder. Key tests include the anterior test, performed supine, where you abduct the arm to 90 degrees, externally rotate it, and then apply an anterior subluxing force to the humeral head. The posterior test is done seated, with the elbow flexed to 120 degrees, shoulder abducted and flexed, horizontally adducting while applying posterior oblique pressure.
Pushing forwards and backwards on the joint.
Gently, yes. The sulca sign test involves pulling inferiorly on the arm to see if a depression forms between the acromion and humeral head, which indicates multidirectional instability, or MDI. And finally, the apprehension test, performed at 90 degrees abduction and end-range external rotation, is positive if it provokes apprehension, a feeling that the shoulder is about to dislocate, not just pain, strongly suggesting anterior instability.
Apprehension, not just pain. Key difference. And for rotator cuff, or RC, pathology, you need some quick screening tests to pinpoint the problem. A quick screen for full-thickness tears involves assessing the client's inability to hold their arm in abduction and internal rotation against resisted external rotation. If they can't maintain that position or it collapses, it's a positive sign suggesting a significant tear.
The drop arm type tests.
Exactly. For the infraspinatus tendon, you'll use the PAT test. The arm is positioned in 90 degrees abduction with neutral rotation in the scapular plane, and you apply resistance to shoulder external rotation at the wrist. Weakness or pain here implicates the infraspinatus.
Testing external rotation strength.
Right. And for the subscapularis, the Gerber liftoff test is key. The client places the dorsum of their hand on their posterior iliac crest, their lower back, and actively lifts their hand off their back against your resistance.
Testing internal rotation strengths from behind the back.
Correct. These tests help you quickly pinpoint the specific muscle or tendon involved in the rotator cuff. 3. The art and science of intervention. Guiding recovery. All right, now that we've diagnosed and assessed, let's shift to the art and science of intervention, where we translate all that knowledge into action to truly guide recovery.
Where the rubber meets the road.
Exactly. Let's start with edema management, which is truly the foundational cornerstone of successful hand healing. The core principle here is that edema control is absolutely key to successful clinical outcomes and should always be among the highest priorities in a hand therapist's plan of care.
Got to get the swelling down. First priority. Often.
First priority. Why? Because unchecked swelling can lead to stiffness, pain, and scar formation that severely limits function. Modalities are important, but they are always an adjunct to treatment, a helper, not the sole solution.
That emphasis on edema control is paramount. And what's truly fascinating are the specific techniques we use. Elevation is foundational. Gravity assists with fluid drainage, so you want to use it to your advantage.
Head above heart.
And more specific than that, actually, the most effective position for upper extremity elevation is quite specific. The elbow higher than the shoulder, the wrist higher than the elbow, and the hand higher than the wrist, with the elbow more extended than flexed.
Okay, a whole cascade of elevation.
Exactly. This sequential positioning creates a clear pathway for fluid drainage. Active range of motion, or AROM, is another incredibly powerful method to prevent and reduce edema. It works like a pump.
The muscle pump.
Promoting fluid drainage by muscle contraction and actively discouraging the formation of adhesions, those sticky bands of scar tissue that limit movement. The exercises must always be customized to the client's specific injury or surgery and any medical contraindications, but getting those fingers, wrist, and elbow moving even slightly is crucial.
Keep things moving gently. Then there's manual edema mobilization, or MEM. This technique is based on the intricate anatomy and physiology of the lymphatic system, which is the only pathway for interstitial proteins, those large protein molecules that accumulate in swollen tissue, to return to circulation.
Right, the proteins are too big for blood vessels after a few days.
Exactly. At 6 to 12 days post-injury or surgery, these protein molecules are simply too large to be reabsorbed through the regular blood vessels, so they rely entirely on the lymphatics. MEM involves light, precise mobilization of the skin, first proximally near the elbow and shoulder, then distally around the hand and fingers, massaging over proximal lymph nodes, and promoting flow in the anatomical direction of the lymphatic pathways.
Working proximal to distal, then distal to proximal, clearing the path.
Precisely. This facilitates the removal of excess fluid and the protein molecules that continue to attract water if not recirculated, keeping the swelling round. Here's a crucial clinical pearl, something you'll want to etch into your memory. Use very light pressure, just enough to gently move the skin.
Light touch is key, not deep massage.
Absolutely not.
No.
Why? Because deep or heavy massage pressure actually collapses the delicate lymphatic network and is counterproductive or even injurious. MEM is most effective for clients with persistent edema who have intact but overwhelmed lymphatic systems, but it's important to know the contraindications. Infection, active blood clots, congestive heart failure, renal failure, or active cancer, as it can inadvertently spread these conditions.
Got to know when not to do it. Important safety point. And that careful touch extends to compression techniques. Edema gloves provide gentle, uniform compression, typically 15 to 25 millimeters of mercury, which stimulates the superficial lymphatic system and supports the soft tissues.
Like isotoner gloves, sort of?
Similar concept, yeah. These gloves are usually made of nylon and spandex and should extend only to the middle phalanges to allow for sensory input at the fingertips. It's absolutely vital they're not too tight, especially at the distal edges.
You don't want a tourniquet effect.
Exactly. as this can paradoxically worsen distal edema by creating a tourniquet effect. Elastic tubular stockinette offers another option for gentle compression, made from a cotton round blend with latex, so always be cautious about latex allergies.
Like Tubi Grip.
Like Tubi Grip, yeah. It can be cut to size, worn with gloves, and a safe guideline is that the therapist should always be able to get a finger inside the sleeve, ensuring it's not too constrictive. Both types of compression garments are reusable. Clients should be given 2 pairs, one to wash, one to wear, and instructed to wash them with warm, soapy water and air dry. Always, always monitor the skin for marks indicating tightness or irritation.
Check the skin frequently. And while not core, modalities can be useful adjuncts in certain situations. Contrast baths are sometimes suggested to create a pumping effect from vasodilation and vasoconstriction, the expansion and contraction of blood vessels, theoretically aiding edema reduction.
Hot and cold water dips.
Right, you would alternate soaking the hand in warm and cold water. However, research has conflicting evidence on their actual effect on edema, even if they superficially increase skin temperature and blood flow and feel good to the patient.
Feels good. But does it really help the swelling much? Jury's still out.
Seems so. They're contraindicated for open wounds, poorly controlled epilepsy, hypertension, and diabetes, so be cautious. As for electric stimulation, it can be helpful when a client can't perform effective active muscle contractions on their own.
When the muscle pump isn't working well.
Exactly, as muscle contractions inherently stimulate venous and lymphatic circulation, acting as a pump. The current intensity must be high enough to elicit a visible muscle contraction, and clients should be encouraged to actively contract their muscles simultaneously with the e-stim for maximum benefit.
Get them to work with the machine.
Definitely. Be aware of contraindications like deep vein thrombosis, thrombophlebitis, impaired sensation, nerve regeneration, as it can interfere, impaired circulation, and chronic wounds.
Lots of precautions with e-stim, too.
Yeah.
Now, let's dive into fracture rehabilitation, optimizing both bone and soft tissue healing, which are equally important for a good functional outcome.
Healing the bone and keeping things moving.
That's the balance. Understanding healing principles is paramount. Primary healing occurs when you have rigid fixation, such as plates and screws holding the bone together, allowing less than 1 millimeter of motion at the fracture site.
With surgery, basically. ORIF.
All right, ORIF. This bypasses the inflammatory and repair phases, allowing direct regrowth across the fracture and often earlier wrist motion. In contrast, secondary healing occurs with non-rigid fixation like casting, orthosis, external fixation, or intramedullary fixation.
Casting, splinting.
Exactly. Healing here is actually enhanced by micromotion, small, controlled movements, which stimulates callus formation. This process involves 3 overlapping phases. The inflammatory phase, the repair phase, where soft callus forms and ossifies at 4-6 weeks, and the remodeling phase, which takes 3-6 months for full restoration of bone strength.
Inflammation, repair, remodel.
Yep. Here's a crucial clinical pearl. The absence of pain or tenderness at the fracture site defines clinical healing. This is your earliest real-time indicator that the bone is becoming stable even before an X-ray confirms full bony union.
So no pain on palpation means it's likely stable enough to start moving more.
Generally, that's a good sign to progress, with surgeon guidance, of course.
When it comes to intervention strategies, orthosis use is absolutely essential for protecting and guiding healing. And orthosis supports the healing bone by providing a conforming exterior shell that controls motion of joints proximal and distal to the fracture in the early weeks.
Protecting the fracture site.
Right. As healing progresses, the orthosis can be modified to permit controlled motion exercises, applying gentle stresses to both the soft tissue and bone, and then further modified to allow full joint movement while still providing protection for functional hand use and continued bone strengthening.
So the splint changes as healing progresses.
It should. For example, for middle phalanx fractures, a dorsal finger-based orthosis with the PIP and DIP joints in extension and a volar strap can provide stabilization. An alternative is a volar finger-based orthosis that blocks the long flexors but is removed for exercises. A hand-based orthosis is used if multiple fingers are involved.
Different designs for different needs.
Exactly. For distal phalanx fractures, a clamshell or cap finger-based orthosis is typical, covering the dorsum and allowing PIP motion, worn full-time for 4 to 6 weeks. An alternate clamshell can help control FDP forces. For proximal phalanx fractures, a hand-based orthosis with the MCP joints flexed 70-90 degrees and IPs extended is used.
That intrinsic plus or Safe positions, well,
Exactly. Why this position? Because it provides excellent stability and minimizes adherence of the extensor and flexor tendons, preventing stiffness. Here's a clinical pearl. For ORF, or open reduction internal fixation cases, an orthosis is still required to minimize micromotion.
even with plates and screws.
Even the plates and screws initially. But immediate joint motion of joints proximal and distal to the fracture is imperative to offset the biological response of surgery and prevent stiffness. Less stable gray zone fractures, however, require delaying controlled active motion until more bony stability is achieved.
So early motion is key after ORIF, but still protect the site. It's a balance. And that insight into controlled motion is central to minimizing stiffness and adhesion after a fracture. Controlled motion and exercise are crucial. Your exercises must be customized in terms of the arc of motion, whether it's no motion, controlled motion, limited, or full. And the type of motion: passive, active-assisted, active, or resisted active.
Tailoring the exercise prescription.
Absolutely. For P1 fractures, for instance, positioning the MCPs and moderate flexion for AROM of the IPs provides stability to the fracture site and maximizes tendon excursion, meaning the tendons can glide fully. You can also isolate the IPs for FDS and FTP excursion.
Getting those tendons moving to prevent scarring down.
Precisely. General guidelines suggest performing 5-10 repetitions 5 times per day with stretches held for at least 5 seconds. A golden rule. Always avoid painful exercises, as pain can lead to increased inflammation and guarding.
No pain, no gain does not apply here.
Definitely not. Post-ORIF, you'll begin gentle and controlled AROM in all planes once the fixation is deemed stable by the surgeon, typically around 10 weeks post-surgery, progressing to PROM as needed, and then to strengthening and resistive motion activities, or RMA programs.
Looking at the timeline and progression for fracture rehabilitation, it's helpful to think in phases. The acute phase, 0 to 6 weeks, primarily focuses on immobilization and protection of the fracture site. Early referral to therapy, ideally within the first week, is critical even while immobilized.
Get therapy involved early, even in the cast.
Yes. Here, your focus is on aggressive edema control and maintaining tissue length in the uninvolved joints. AROM of the unaffected joints acts as a pump for fluid drainage, and elevation elbow and hand higher than the heart assists gravity in reducing swelling.
Keep everything else moving.
Exactly. In the later clinical reasoning phase, 3 to 8 weeks, as the bone begins to heal, you'll start to critically distinguish between intrinsic versus extrinsic tightness, capsular restrictions, and tendon adhesion to truly tailor your treatment, as each requires a different approach.
Figuring out why it's stiff. Is it the joint, the muscle, the tendon?
Right. When it comes to return to function, light activities like video games are typically appropriate around 3 to 6 weeks. Higher demand activities like riding a bike or lifting a loaded backpack can be introduced around 6-8 weeks, often still with an orthosis for protection. Unrestricted use is typically advised around 12-16 weeks, always guided by surgeon consultation and follow-up x-rays to confirm bony union.
Gradual return to activity, guided by healing. That phased approach is key to guiding recovery, and it also sets the stage for addressing potential complications. CRPS, which we discussed earlier, requires early detection and a multidisciplinary approach, including medication, psychological support, and therapy. You'll rigorously monitor for the cluster of symptoms: persistent pain, discoloration, temperature changes, mottling, sweating, changes in hair growth, and stubborn edema.
Vigilance for CRPS signs.
Constant vigilance. Scar massage should be initiated once pink, closed scar tissue is present, typically after sutures are removed. Use unscented lotion with circular motions and enough pressure to blanch whiten the tissue 2-3 times per day for 5 minutes to mobilize the scar and desensitize the area, preventing adhesions.
Getting that scar moving and less sensitive.
Crucial. Desensitization is crucial for hypersensitive scars or digital nerves, which are common after crush injuries. This typically starts 10-14 days post-injury, using textures ranging from soft cotton to rougher materials like Velcro to gradually normalize sensation.
Bombarding the nerve with normal input.
Basically, yes. Retraining the brain. For pain management, you can use medication, ice, heat, if edema is resolving, contrast baths, and graded motor imagery, or GMI, which involves mental exercises to rewire the brain's perception of the limb. For post-DRF, passive wrist flexion and supination stretches, like towel stretches, are often beneficial for regaining motion.
Lots of tools in the pain management toolbox. Let's move on to tendinopathy interventions, which truly focus on restoring tendon glide and strength, often a long but rewarding process. We typically follow a 2-phase approach.
Phase 1, Phase 2.
Phase I is all about pain relief and tendon lengthening. This starts with essential client education on the pathoanatomy of tendinosis, explaining that it's a degenerative process, not just inflammation emphasizing activity modification.
Stop doing what hurts it.
Fundamentally, yes. Avoiding painful activities like palm-down lifting for lateral epicondylosis and teaching proper body mechanics to prevent re-injury. It's vital to manage client expectations that full resolution of pain can take several months, as patience is key.
These things take time to heal. It's not overnight.
Definitely not. For pain management, ice over the tendon origin can be used, taking care to avoid applying it directly over superficial nerves like the radial or ulnar nerve. Stretching is the cornerstone for pain reduction in this phase, addressing the tendon length insufficiency due to scarring.
Stretching to lengthen the degenerated tendon.
Right. For lateral epicondylosis, instruct the client to use their unaffected hand to passively flex and ulnarly deviate the wrist gently with the elbow in full extension, stretching the extensor muscles. For medial epicondylosis, it's wrist flexors, stretched in supination with the elbow extended and wrist passively stretched into extension. Stretches should be held in a pain-free range for 20-30 seconds, 3 to 5 repetitions every 2-3 hours.
Frequent, gentle stretching.
A clinical pearl. If radial tunnel syndrome is suspected, avoid a counterforce strap and instead add radial nerve glides, as you don't want to compress an already irritated nerve.
Good point. Don't make the nerve angrier. That comprehensive phase 1 is critical, and it really sets the stage for phase 2, strengthening. While the literature previously debated the need for strengthening in tendinopathy, the current clinical consensus for lateral epicondylosis is that eccentric strengthening is the most critical component of rehabilitation.
Eccentrics, lengthening while contracting.
Exactly. This involves loading the tendon in a lengthened, pain-free position, for example, slowly lowering a weight against gravity. You typically start with 10 repetitions, 1-2 times per day, using a very light weight, like a 1-pound dumbbell, slowly progressing to 30 repetitions for endurance, and then increasing to a 2-pound weight, or even more as tolerated.
Start light, progress slowly. Focus on the lowering phase.
Precisely. Always instruct the client to stretch both before and after strengthening exercises to maintain tendon length and prevent soreness. As pain-free activities return, they can gradually reintroduce previously avoided tasks, often guided by functional scales.
Getting back to life, slowly but surely. Orthososes also play a significant role in tendinopathy management by resting the involved structures. For lateral and medial epicondylosis, a wrist cock-up orthosis can be beneficial by keeping the wrist in a neutral position, which shortens the extensors or flexors at the elbow, reducing tension at the epicondyle.
Resting the wrist to rest the elbow tendons.
Exactly. For de Quervain's tenosynovitis, a forearm-based thumb spica orthosis is recommended, placing the wrist in neutral and the thumb in opposition, with the IP joint free to allow finger flexion. It should be worn day and night for 4 or 6 weeks, coupled with ice and complete cessation of exacerbating activities.
Immobilize that thumb and wrist.
A useful clinical pearl for new moms. A radial side forearm-based thumb spica can be custom fabricated to avoid interference during infant feeding, allowing the thumb to clear the baby's head.
Practical adaptation, nice.
For trigger finger, a hand-based orthosis with the MP joint in neutral, or a digital volar gutter orthosis with the PIP joint in neutral, leaving MP and DIP free, is often prescribed to prevent the tendon from catching at the A1 pulley.
Stop the finger from bending at the base.
Right. Corticosteroid injections administered by physician can provide short-term pain relief, 1 to 4 weeks, but therapy should always follow to address the underlying mechanics.
Injection helps the pain, therapy fixes the problem, hopefully.
That's the goal. Surgical intervention is usually considered only after 6-12 months of debilitating pain despite consistent conservative care. Post-op, the focus shifts to meticulous scar management and edema control, with gentle stretches starting around 6 weeks and full recovery typically taking 6 to 8 weeks.
That thorough review of tendinopathy interventions leads us to perhaps the most intricate area, nerve injury interventions, truly restoring function and sensation.
Back to the nerves.
Back to nerves. The fundamental principle here, and one you'll repeat often to your patients, is motion is lotion for our nerves. Gentle, controlled movement is key to promoting nerve health. Avoid the no pain, no gain mentality, as aggressive tension can exacerbate symptoms and further damage a healing nerve.
Gentle movement is key. No aggressive stretching of nerves.
Absolutely not. In conservative management, orthoses play a crucial protective and supportive role. For radial nerve palsy, an orthosis facilitates functional grasp and release by assisting wrist and finger extension, and prevents joint contractures. It's typically worn starting around 6 weeks post-injury until motor return or tendon transfers are performed.
A dynamic extension splint, often.
Often, yes. An example would position the wrist in 30 degrees extension, MP joints 10 degrees flexion, thumb in radial abduction extension, with IP joints free. For DRSN, or dorsal radial sensory nerve, compression, a volar forearm-based thumb orthosis with wrist extension and thumb retroposition can minimize tension on the nerve. A clinical pearl here: always monitor the distal forearm strap and consider cutting out the radial styloid area to prevent compression directly over the nerve.
Modifying the splint to avoid nerve pressure points.
Critical. For pronator syndrome, a forearm-based orthosis, with hand included if FDS arch compression, is worn as much as possible for 2-3 weeks, removed only for hygiene and gentle AROM and nerve gliding. For carpal tunnel syndrome, or CTS, a wrist cock-up orthosis with the wrist in neutral, especially worn at night, is a common conservative approach, aiming to reduce pressure in the carpal tunnel.
Night splinting for CTS is very common.
Very effective often. In cubital tunnel syndrome, limiting elbow flexion, for example with a bath towel splint while sleeping, which can gently hold the elbow straight, and using a padded elbow sleeve during the day helps protect the ulnar nerve.
Keeping the elbow straight at night.
Yes. For ulnar nerve palsy with clawing, a dorsal MP joint blocking orthotic with MP joints in flexion or a hand-based anti-claw splint allows for full finger flexion while stabilizing the MP joints and preventing hyperextension.
Preventing that claw deformity.
Exactly. For Gans canal compression, padded anti-vibration gloves or custom padded gloves can protect from external irritation.
Then there are nerve gliding exercises. These are absolutely crucial for promoting the longitudinal sliding of nerves within their sheaths, not tensioning them.
Gliding, not stretching. Big difference.
Huge difference. The goal is to enhance blood flow and axoplasmic flow, the transport of vital substances within the nerve, while minimizing adhesions that can restrict nerve movement. Sliders are preferred over tensioners, as they promote movement without creating excessive stretch on the nerve.
Sliders are safer.
Generally, yes. A great example for the median nerve is the Show Me the Money glide. Start with the hand in a gentle fist, wrist, and forearm neutral, then slowly open the hand with the forearm supinated and the wrist in extension, as if showing what's in the palm.
Gentle sliding motion.
These exercises must be performed slowly and deliberately, and the client should stop immediately if numbness, discomfort, or pain increases. Integrating these movements into functional activities makes them easier to remember and more meaningful for the client's daily life. Ergonomic modifications are also key to conservative management.
Changing how they do things.
Right. Clients should be educated to avoid repetitive movements and sustained postures that aggravate the nerve, such as using a headset for phone calls instead of bending the elbow, using a split keyboard, or ergonomic tools like hammers. Good posture and frequent stretch breaks throughout the day are essential.
Simple changes can make a big difference.
They really can. Desensitization techniques are used for hypersensitive areas post-injury, which are common after crush injuries, typically starting 10-14 days after the injury, using various textures and pressures. For pain management, modalities like ultrasound, iontophoresis, TENS, hot packs, fluidotherapy, paraffin baths, and cryotherapy can be used as adjuncts, but be cautious with superficial heat or cold if there's loss of protective sensation, as the client won't be able to feel if the temperature is too extreme.
Safety first with modalities if sensation is impaired.
Always. Manual techniques like scar massage and therapeutic touch, coupled with stress management, relaxation, visualization, and activity pacing, can also aid in pain reduction and overall well-being.
That comprehensive approach to conservative care is vital. Now, let's consider post-operative management after surgical intervention for nerve injuries. General guidelines for nerve repairs involve immobilizing the fewest joints possible without compromising the repair, striking a delicate balance between protection and early motion.
Protect the repair, but move what you can.
That's the goal. Gentle AROM can begin fairly early, anywhere from 2-3 days to 2-3 weeks post-op, depending on the surgeon's protocol and the specific repair, but strengthening should be delayed until the remodeling phase, typically 3 to 4+ weeks, to allow the nerve to heal.
Delay strengthening after nerve repair.
Definitely. For nerve repair, laceration, such as a radial nerve laceration at the elbow or proximal forearm, an orthosis with the wrist in 30 degrees extension is typically used to protect the repair, with MP joints at about 10 degrees flexion, thumb in radial abduction extension, and IPs free for early AROM. For a high median nerve laceration, early active motion is recommended, but if the pronator teres muscle was released and reattached, active pronation and end-range supination should be avoided for 4 to 6 weeks to protect that surgical site.
Specific precautions based on the surgery.
Always. For ulnar nerve lacerations, a dorsal blocking orthosis with the wrist in 20-30 degrees flexion and an MP dorsal block to 45 degrees is used, allowing immediate AROM and PROM if no concurrent tendon injury. Scar massage and desensitization begin once sutures are removed.
For nerve decompression entrapment, recovery is typically quicker since the nerve itself wasn't severed.
Just releasing the pressure.
Right. After a carpal tunnel release, or CTR, or endoscopic carpal tunnel release, ECTR, full range of motion is usually allowed immediately post-op after the initial bulky dressing is removed, and scar management is then key to prevent adhesions.
Get moving quickly after CTR.
Usually. For pronator syndrome or anine decompression, early active motion is encouraged to prevent stiffness. And for Guillen's canal decompression, a bulky dressing is applied and full ROM is allowed immediately post-op. Beyond the physical, addressing psychosocial aspects is absolutely paramount in nerve injury rehabilitation.
The mental and emotional side. Hugely important.
Hugely. Clients are often fearful of injury, re-injury, and may have unrealistic recovery expectations leading to anxiety and frustration. It's critical to address their pain, sleep difficulties, and potential depression, as these significantly impact their ability to participate in therapy and return to work and leisure activities.
Got to treat the whole person, not just the nerve.
Exactly. Educating clients about the cause of their pain, providing realistic timelines for recovery, and empowering them with self-management strategies contributes to better outcomes and adherence to their home programs.
Finally, let's explore shoulder interventions, recognizing how crucial proximal mobility is for distal hand function. For proximal humerus fractures, the initial phase involves wearing an immobilizer, but clients should still perform gripping exercises and active range of motion of the elbow and wrist to prevent edema and stiffness in the more distal joints.
Keep the hand and elbow moving while the shoulder heals.
Essential. The sling is typically worn in public and while sleeping for the first 6 weeks to protect the healing fracture. Once stability is achieved, around 4 to 6 weeks, PROM exercises like pendulum swings and tabletop exercises, where the patient uses their body to passively move their arm on a surface, can begin.
Gentle passive motion first.
Right? AROM then focuses on proper glenohumeral and scapulothoracic movement to prevent substitution patterns like early scapular elevation or trunk leaning, which can lead to other issues. Hand-to-hand, AROM, mirroring exercises, self-scapular stabilization, and wall walking are all beneficial for regaining controlled movement. A clinical pearl to calm client fears of instability. Have them gently feel their humeral head move during gentle rotation, or even listen with a stethoscope to sound transmission across the fracture site, which can be reassuring.
Helping them feel the stability returning. And as for progressive strengthening with proximal humerus fractures, closed chain exercises are introduced first as they provide more stability. Think wall push-ups, seated press-ups, weight shifting in quadruped, and ball rolling against a wall or tabletop.
Closed chain first, more stable.
Right. If functional ROM and normal movement patterns are achieved by 12 weeks post-injury, more dynamic plyometric exercises can be initiated. For thoracic outlet syndrome, or TOS, or brachial plexopathy, core management strategies include diaphragmatic breathing, adopting safe sleeping positions to minimize plexus stress, and maintaining posture that minimizes plexus tension.
Breathing, posture, positioning. Foundational for TOS.
Foundational. Strengthening focuses on scapular stabilizers and elevators, including the upper, middle, and lower trapezius, levator scapulae, rhomboids, and serratus anterior, often with resistance bands or light weights. These should be done in sets of 3 repetitions, assessing for any irritation between sets to avoid aggravating the nerves.
Strengthening the muscles around the shoulder blade and neck carefully. That detailed approach to scapular stability is foundational for TOS. And it leads us to consider nerve mobility in TOS. Scapular proprioception can be regained through visual feedback exercises like the scapular clock, where the client performs scapular motions while facing a mirror, targeting points of a clock to improve control.
Improving awareness of scapular position.
Exactly. Nerve gliding and stretching are vital to improve the mobility of the brachial plexus. Glides begin with arms at the side, elbows flexed to 90 degrees, palms up, elevating shoulders, and slowly extending elbows. You can bias the medial and lateral cords, which are part of the brachial plexus via the median nerve by maintaining supination with wrist extension, or bias the posterior cord via the radial nerve by pronating forearms and flexing wrists. The oscillating brachial plexus stretch is also key for increasing mobility.
Gentle glides for the whole plexus.
Soft tissue. Stretching of the surrounding muscles is also crucial. Scalene stretches should be performed with the shoulder elevated, anchoring the first rib to relieve tension from the brachial plexus. The pectoralis minor doorway stretch involves a shoulder shrug first to enhance the stretch and increase the costoclavicular space aperture. A crucial clinical pearl here. Perform nerve glides between stretches to minimize neural irritation,
Glide between stretches, okay.
ensuring you're not just stretching the nerve itself, but improving its ability to move freely.
For adhesive capsulitis or frozen shoulder, treatment is rigorously phase-specific. In the freezing phase, the primary goal is to prevent further motion loss while managing pain. A corticosteroid injection may help reduce inflammation, but you must avoid overstretching as it can actually enhance inflammation and prolong recovery, making the patient worse.
Gentle in the freezing phase.
So gentle. This is a common mistake for new therapists. In the frozen and thawing phases, more aggressive stretching is appropriate, but again, avoid pushing to the point that reinitiates inflammation. Functional adaptation is crucial throughout, especially for clients with bilateral frozen shoulder, so occupational therapists will assist with ADL modifications and adaptive equipment for grooming, bathing, and dressing.
Helping them cope functionally while it's stiff.
Exactly. For unilateral cases, workstation modification can help maintain productivity and reduce strain. It's important to remember there's no evidence that modalities like ultrasound or interferential e-stim affect outcomes. In fact, passive modalities may actually prolong recovery by making the patient less active in their own recovery.
Focus on active movement and stretching when appropriate. Finally, for shoulder instability, treatment focuses squarely on strengthening the rotator cuff and scapular stabilizers. You'll start with shoulder isometrics in a safe, non-provocative position, such as the arm at the side, emphasizing setting the scapula, engaging those muscles to stabilize the shoulder blade.
Isometrics first.
Then progression moves to isotonic exercises in a sub-impingement range, using light resistance and high repetitions to build endurance and control. For anterior instability, the focus is on strengthening internal rotators, adductors, and biceps, which help to keep the humeral head centered.
Strengthening the front muscles for anterior instability.
Makes sense, right? For global instability, meaning looseness in multiple directions, you'll target the entire rotator cuff, scapular stabilizers, deltoid, biceps, and triceps, creating a strong muscular corset around the joint. For clients with a tight posterior capsule, the sleeper stretch is beneficial, emphasizing frequency over intensity, aiming for a minimum total of 15 minutes of stretch time daily, even if broken into shorter bouts, is far more effective than one long, painful stretch.
Frequent short stretches beat one long, painful one. Good advice.
So what does this all mean for you? We've covered a massive amount of ground today, from the nuances of a boxer's fracture and the very specific thresholds for surgical intervention, to the subtle art of nerve gliding and the critical phase-specific approach to frozen shoulder.
Yeah, it's a lot to take in. It is. You've seen how each diagnosis demands a truly tailored approach in assessment and intervention, and how seemingly small details, like applying the correct, almost imperceptible pressure for edema mobilization, the importance of consistent measurement, or the exact placement of an orthosis, can make all the difference in a client's recovery trajectory.
The details really matter in hand therapy.
I absolutely do.
If we connect this to the bigger picture, you've gained profound insight into how a hand therapist integrates intricate anatomical knowledge, sharp clinical reasoning honed by experience, and a deep understanding of tissue healing principles to truly optimize patient outcomes. The sheer complexity of the hand necessitates a holistic approach, always considering the interplay between bones, soft tissues, nerves, and even the broader upper extremity, right up to the shoulder. It's about seeing the entire system, not just the isolated injury, and empowering your patients to heal.
That holistic view, connecting everything up the chain. This raises an important question. As you prepare for your fieldwork, how will you not only master these techniques and apply this vast knowledge, but also truly partner with your clients, empowering them with the understanding and confidence to navigate their own healing journey?
Yeah, making them an active participant.
Exactly. Becoming an active participant in their recovery rather than just a passive recipient of care, something to mull over as you continue your deep dive into this incredible and rewarding field.